Hey everybody, and welcome back to another video here at Whiteboard Medicine. We appreciate you checking it out. We're bringing you another Whiteboard Medicine Essentials video today where we bring some videos back from the archives and put them together into kind of higher yield, more comprehensive video. And today we're going to be doing advanced EKG bundle branch blocks, specifically going through right bundle branch blocks and left bundle branch blocks. How do you diagnose them? Why are they relevant? What makes them different? What makes them similar? And we'll go through them on actual 12-lead ECGs. So stick around, quick 30-second break for the introduction. Don't go anywhere, then we'll dive into bundle branch blocks. Everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this.
Today we'll be talking about right bundle branch block. This is going to be a 5-minute EKG episode where we try to stick as close as we can to 5 minutes, although we tend to fail that. So right bundle branch block, what is it? First, just quick, I thought we could start with kind of just the general pathophys. So I drew what is a poor version of a heart over here, right? This here to label, right? This is the SA node. Here's our AV node. Here's our bundle his. Here is our, let me see, rights and lefts, left bundle branch, right bundle branch. So what is a right bundle branch block? So like it described, it's where this right bundle, for whatever reason, does not conduct and depolarize the myocardium around it the way it should. So when a depolarization goes through, right, we go this way, through the atria, from the SA node through the atria towards the AV node, then we go through the bundle of his, and what we should do is go through the left bundle branch and the right bundle branch and depolarize both those, and that will give us our typical EKG, right? POA for the atria, then we do our Q, R, S, and then we repolarize with our T. So what's happening in this QRS complex, right, is that we're going through the bundle of his, then we get our left ventricular and right ventricular depolarizations to make this R and S waves. So in a bundle branch block, when you have the blocked right bundle, whether from a structural change or right heart strain or ischemia, your QRS morphology is going to be different. So how is it going to be different? Well, let's talk about it, because that'll get us into the diagnostic criteria here. So right bundle branch, number one, since our depolarization through the ventricles is slowed because of the bundle branch, we're going to have a widened QRS. That is a QRS that is greater than 120 milliseconds. All right, that makes sense, right? Because our depolarization going from the AV node through the bundle of His and the bundle branches is slowed because there's that block. So the QRS is going to take longer and be widened as compared to normal. Good. The other thing, criteria-wise, is that we get this RSR prime that's primarily in V1 and V2, or at least most notable. So why V1 and V2? Well, since this is a right bundle branch block, the right side of the heart is going to be most effective, which means those right precordial leads, V1 and V2, are going to be most highly effective, right? We can draw a little human here. This is going to be a really bad drawing of a human. Right, there's going to be their head up there. Those are two nipples. And then we have, right here, we have V1, V2, and then 3, 4, 5, 6. So these are the right-sided precordial leads, and those are going to be most effective. So you'll be able to notice your R prime most pronounced in those right-sided leads. What else? So those are the two main categories. Now just kind of a couple shout-outs here. First shout-out is that T waves are going to be discordant to the terminal QRS, which means you're going to have inverted T waves in the right-sided precordial leads. So I'll write this out here. So you're going to have inverted T waves in the right precordial leads. Right precordial leads. Okay, good. And the other thing, which is something we don't often look at in the clinical setting, but technically leads 1 in V6, the duration of the S wave should be greater than the duration of the R wave. So in leads 1 plus V6, the duration of the S wave should be greater than the duration of the R wave. Oh, S duration, oh, I didn't do any of that right. Let's erase this quick. So the duration of S should be greater than the duration of R. So how does this translate into the real setting? Well, let's go over to our EKG over here, and let's go through our criteria, right? So first is that the QRS complex is greater than 120 milliseconds. So it's going to be tough to count out each individual box given the zoomed out quality of this, right? But each small box is 0.04, right? So you want the QRS to be more than 3 small boxes. So let's go to here, and we see the start is here, and the end is over here. Now if we count this, you might have to just trust me, but this is going to be greater than 120 milliseconds. So we have a widened QRS. So what that tells us, a widened QRS, is that there's some kind of bundle branch block going on, but it doesn't tell us what kind of bundle branch block. Could be left bundle branch, could be left anterior fascicular, could be bifascicular, could be right bundle branch. By the way, we have a video on left bundle branch block, which I'll link up above in the right corner, but we just know now with the QRS greater than 120 milliseconds that there's a bundle branch block going on. So now what type of block is this? So we can first look in our right-sided leads, right? So we have V1, V2, even V3 to some extent, and we want to see what the morphology of this QRS is. Do we have this R, S, R prime? So now let's go through and label, right? So we have a Q wave here, we have an R wave here, we come down with our S wave, and then we have this second upslope. That is the R prime. What that means here, just going up here, right, is you have your Q, which you don't see, R, S, and then you come back, and then there's another hump, which is the R prime. But you have this S in between the two R's. It's not that you just go, you know, Q, and you have an R, and then another R, because you have this, because there's no S here. This is not R prime. R prime is where you have your R, you go down to your S wave, which is here, and then you have an R prime. And you can see that in each of these, right? We can label the S, R prime, R, right? You have an R here, you have your S, you have your R prime. You can go to any of these. You have your R here, you have your S, you have your R prime. You see that? I mean, we can go throughout all of them and do that. You can go up here, you have your R, S, R prime. So that is like the pathognomonic, I shouldn't say pathognomonic, the stereotypical morphology of the QRS in a right bundle branch block, because you have a prolonged QRS, which is more than 120 milliseconds, and we're in 3 small boxes. And then you have your RSR prime, which is most apparent in V1 and V2 because of those are the right-sided precordial leads. Now, a few other shout-outs, right? One thing to note is that you often have inverted T waves, and you can have some kind of fake ST depressions in the right precordial leads. So let me erase some of this to clear it up for us. And then we'll just look at this here, right? So we have our P, R, and this would be kind of ISO, your baseline, and then you have this dip here. In a right bundle branch block, this is actually normal. You expect an inverted T, right? Here's your T wave here, and it's inverted. You can get a little pseudo ST depression in these right precordial leads. So if you go and look in all these leads, you can see on the right side that you get these inverted T waves, right? These are all the T waves, and they're all inverted with what looks like a little ST depression, which is a normal variant. Okay, and then I'll just shout out to this quick because it's not really worth spending much time on, but the last little point is in leads 1 and V6, the duration of S is greater than the duration of R. So that means, you know, this duration of S is greater than this duration of R. So it's the wave themselves. So right, you can do Q, you have R. Well, that's not going to be helpful because that's not drawn well. Good. So you have your Q, R, and then your S, right? The duration of this S is greater than the duration of this R. But again, smaller thing. The big thing to remember is going to be these 2 points, widened QRS, and then your RSR prime in the right precordial leads. So that is your right bundle branch block. The reason you get that right is because your left bundle branch is going to depolarize the left ventricle first, give you your QRS, and then after that, this depolarization is going to travel over to the right ventricle, creating that R prime. Left, that's an E, bundle branch block. I could have just abbreviated it, but we wrote it out because we care. Left bundle branch block. Okay, so I have a 12-lead EKG from a patient I've seen previously with a left bundle branch block, which we're going to use to demonstrate left bundle branch block findings on 12-lead EKG. I did just want to briefly, though, go over this beautiful drawing of a heart and the conduction system. As a quick reminder, just briefly about the conduction system in the heart will help guide us in terms of understanding left bundle branch block. So conduction system, just quickly, we'll have a node here, SA node, we'll have a node here, AV node, then we'll have a single here bundle of His, and then you have your right bundle branch that comes out this way into your Purkinje fibers, and then you'll have your left bundle branch coming out this way into your Purkinje fibers. And we can just label that just real quick. So this is SA, AV, bundle of His, and then your left bundle branch right, that's an R bundle branch, and then you have your Purkinje all over. Okay, so usually, and these are on both sides, Purkinje, I'll just abbreviate that one. So usually, right, your conduction goes, you get your SA node, and we come all through the atria, and we go down into your AV node, right? And then there's a little slowing here. We go down the bundle of His, and then we go into the left and right bundle branches. In a left bundle branch block, you have a block in the left bundle. That means the depolarization you're going to get through the heart is actually going to preferentially go to the right, and then you're going to depolarize the left side through the septum here. And that's how the left ventricle depolarizes. Because of that, you're going to have findings on 12-lead EKG that represent that. So the first thing, because you have a slowing of depolarization through the ventricles, you're going to get a widened QRS. I am going to white out a little bit of our strips down here just to give us a chance to write down some of the definitions. We won't need this area anyway. Good, let me switch back over to pen. So, number one, we're going to get a widened QRS. If you have questions on intervals such as the QRS interval, I'll link up to another 12-minute EKG video in the top right corner that you can look at. In addition to the widened QRS, we're going to get a dominant S wave in V1. So dominant S in V1. And then you're going to get these broad monomorphic R waves in the lateral leads. So I'm just going to say broad R in lateral leads. And lateral leads, we're talking about what? Think about it for a minute. If you have questions on where all the leads sit, I can link another video in the top right corner that will go over all the leads, limb leads, and precordial leads. Your lateral leads, though, are going to be 1, AVL, V5, V6. Okay, so we're going to leave those down there, and then we'll go to the EKG itself to talk about some of these things. So in terms of widened QRS, our QRS interval, right, is from Q to R, and the normal is less than 120. If we count the little boxes, This one is widened. I know it's a little blurred. It's probably hard to count all the little boxes here, but this is greater than 120. So we have a widened QRS. You can go to any of the QRS intervals on this EKG. All of them are widened. In addition to that, we talked about, so we'll check that, this dominant S wave in V1. So what that means, if we go to V1 here, right, and we have we'd have, right near Q, then R would be up, and then this is S. And you have this huge dominant S wave in V1. You can see that persistent through V2, V3 as well, but specifically we'll look at V1, and we get this dominant S wave. Dominant. So check that one. And this is kind of, the dominant S wave in V1 is less thought about. Usually we think about this widened QRS and then number 3, which are these broad R waves in the lateral leads. So if we go to our lateral leads, I'm actually going to switch colors here. Let's do it in red. So we go to our lateral leads and I'm going to circle them in red. That's 1, AVL, V5, and V6. And we get these broad R monomorphic waves. I will just go in this EKG specifically in V5. We do not have this broad R wave, right? Because this is an S wave here. R would be going up. So I'm going to cross this out. But in the rest of the lateral leads, 1, AVL, and V6, we see these broad R waves. And what do we see? So in V6 we'll start. We have these broad monomorphic R waves. And if we zoomed in, which we wouldn't, we would see that the R wave had this little notch here. It looked like an M, and you can see that notch a little bit at the top. We call this M notching, and this is typical in left bundle branch block. So we get this broad R wave, widened QRS with this M notching. Now let's flip over to AVL, and again, this is our R. We have this big, broad R wave, and here, if you look closely, it looks like this. It comes up, goes down, it has a little thing that comes up again, and here we call this just notching. We don't call it M notching, but this is just notching. This is another type of notching pattern, such as M notching, that we see in left bundle branch block. So again, we have our widened QRS with this broad R wave in one of the lateral leads and this little notch, which is right here. If we go to 1, we see a similar pattern to AVL. So I'm going to circle it. Here's our R wave, right? And again, you see P, this would be Q, then we go up into our R, it comes down, we get a little notch, and then it comes down the rest of the way, and then we get these T's here. And this again is this notch. So in left bundle branch blocks, we have a widened QRS, right, greater than 120, which we see throughout all the leads. Oftentimes we have this dominant S wave in V1, and remember we have Q, R goes up, and then S would go down. So in V1 you tend to see just this huge dominant S wave, as we saw in our V1, which is in blue. And then for number 3, we have these broad R waves in the lateral leads that tend to be, I'm going to draw arrows here. So we have come up, we have M notching, or we can have just regular notching, which comes down and goes up just a little bit, or we can just have these big monophasic R waves, again, all widened. And these are all R waves and lateral leads. And that is how you diagnose left bundle branch block on 12-lead EKG. I'm going to do another session on Scarbosa's criteria in left bundle branch block, so look for that. If you're interested in seeing that, you can subscribe to the channel and get notifications because it should be posted probably in the next week or 2. Please subscribe, please ask questions, please comment. We'll do our best to respond to each and every one of them. Again, we're a relatively new channel, and we're always looking for more followers and more content that you guys want us to make. So thanks for watching. Have a good, what day is it today? Thursday, and we'll see you next time.